Imagine for a moment you're faced with a medical decision, and it's not just, which treatment, but how it's delivered, maybe the side effects, maybe even the cost. How do policymakers figure out what you actually value in those really complex situations?
Yeah, it's a fundamental puzzle, isn't it? Because preferences are so personal, so varied, you can't just guess what matters most.
Exactly. You need a structured way, some method to uncover those preferences. And well, that's why today we're diving deep into a really powerful tool in health economics, discrete choice experiments. You might see them called DCEs.
That's right. And they're designed specifically to quantify your preferences for healthcare services, different interventions, even broad policies.
And our mission for this deep dive is to unpack a big review of these DCEs. It covers studies published between 2001 and 2008, and it compares them to how things were done earlier, back in the 90s.
Yeah, so we're looking at how the technique has evolved, the challenges that still exist, and maybe some surprising insights that come out of it all, insights that really shape healthcare.
We're going to get into the nitty-gritty of how DCEs are designed, the pretty advanced stats used to interpret the choices people make, and that really big question: do hypothetical choices actually reflect what people do in the real world?
Hopefully there'll be some aha moments about how your preferences are being studied.
So let's start at the beginning. What is a discrete choice experiment at its core?
Okay, so fundamentally, a DCE is what we call an attribute-based measure of benefit. The basic idea is actually quite neat. Healthcare interventions or services, they aren't just one single thing, right?
Right. They have different features.
Exactly. They can be described by their specific features, which we call attributes, and how much you value that service depends on the specific levels of those attributes.
Okay, that makes sense. So in a DCE, you as the respondent, you're shown a series of choices, usually between two or more options, alternatives.
Yeah.
And these aren't just random clicks you're making.
No, not at all. The choices you make, they reveal an underlying pattern. Researchers call it a utility function. It's basically a mathematical way to map out what you prioritize, what you value in that specific context.
Sounds complex behind the scenes.
It is quite interdisciplinary. It pulls together ideas from random utility theory, consumer theory, experimental design theory, and econometric analysis. So, yeah, it's not just a simple survey. It's a rigorous scientific approach.
Designed to answer policy questions.
Precisely. With actual data on preferences.
And the takeaway for you listening is that DCEs give researchers a powerful shortcut. They help understand which specific bits of a health service or treatment people genuinely prefer.
Yeah.
And that can directly influence what healthcare looks like down the line.
Making it hopefully more aligned with what patients actually want and need.
It definitely sounds powerful, and given that potential, it's fascinating to see how fast the method took off. You mentioned the review compared 2 periods. How much growth are we talking about?
Oh, it's quite dramatic, actually. The number of DCE applications in health economics it exploded.
Right.
Between 1990 and 2000, the average was about 3 studies per year.
Okay.
Then, between 2001 and 2008, that jumped to an average of 14 studies per year. In that later period alone, the review identified 114 studies.
Wow, 14 a year. That's a huge leap. Was this just happening in, say, the UK or the US, or was it more widespread?
It really spread out. I mean, the UK was still a big user, yes, but the geographic application broadened considerably. About 23% of the studies in that later period were done in countries where DCEs hadn't really been used before.
Oh, interesting.
Yeah, across high-income, middle-income, and even low-income countries. So its reach really did expand globally.
And did the way they designed the experiments change much beyond just the sheer number?
Yes, some clear trends emerged there, too. Researchers started incorporating fewer attributes. The average number dropped from about 7 down to 5.
Fewer attributes.
Okay. But interestingly, they asked each person to make more choices. The average number of choices per respondent went up from around 12 to 14.
Huh. Fewer things to compare in each choice, but more choices overall. What do you think that suggests? Maybe trying to make it easier to understand each choice?
That's likely part of it. It could suggest they were aiming for, maybe greater clarity for the respondent, less cognitive load for each individual choice, while still collecting really rich data overall.
Makes sense.
And we also saw a big shift towards using interviewers to administer the DCEs. That went up from about 9% to 19%.
So face-to-face rather than just mail-out surveys.
Exactly. Which might indicate, A desire for more controlled data collection, maybe ensuring people understood the task, answering questions as they came up.
Okay, so once they've decided on the attributes, fewer of them now, and how many choices to present more of them, how do they actually create those specific choice sets? Because, like you said, if you tried every possible combination of attributes and levels,
It would be impossible.
what's your...
Astronomically large, yeah.
Right.
So that's the core design challenge. Researchers have to use something called fractional factorial designs. These are clever statistical methods that let them pick a smaller, manageable subset of all possible choices.
A fraction of the total.
Exactly. But they do it in a way that aims to preserve as much information as possible about preferences.
It sounds like a real balancing act, trying to get the most bang for your buck from each choice someone makes without burning them out.
It is. And there's been a definite move towards what are called statistically efficient designs. The goal here is explicitly to maximize the information you get from each response, often using criteria like D-efficiency.
And they use special software for this?
Yeah, specialized software is pretty much essential for constructing these complex, efficient designs. Things like SAS, Speed, SPSS, Sawtooth are mentioned in the review.
But the review also flagged something interesting that wasn't happening yet in the designs back then.
That's right. It's quite noteworthy. Even though it was a known development in experimental design theory, the review found basically no applications of designs that incorporated prior assumptions about the likely results.
What does that mean? Prior assumptions.
It means using existing knowledge or pilot data to sort of pre-tune the design to be even more efficient at estimating the parameters you're most interested in. It's a more advanced technique that just hadn't filtered into the published health DCEs during that specific 2001-2008 window.
Okay, now here's something that really jumped out at me from the review, the reporting. You'd think how the experiment was designed would be crucial information, right?
Absolutely critical for transparency and replicability.
But the review found that a lot of studies weren't clear about it.
Yeah, this is a bit concerning. A significant number, 37% of the studies reviewed, didn't even report the source or the method used for their experimental design.
37%.
And another 28% didn't provide enough detail about how the actual choice sets were created.
Wow. So as a reader or someone trying to use these results, you're kind of left guessing how they actually set up the choices people made.
Pretty much. And that lack of transparency is a real issue.
Mm.
Understanding these design choices is absolutely key if you want to trust the results. If the choices weren't well constructed, or if we don't know how they were constructed, the insights you get might not fully reflect true preferences.
Which could lead to shaky policy decisions based on potentially flawed data.
Exactly. It really underscores the importance of clear reporting and research.
Right. So, okay, let's assume the design is well reported and sound. Once you, the respondent, have made your choices, how do researchers turn those clicks or ticks into actual insights? How do they crack the code?
Okay, so this is where the estimation procedures come in. The responses, your choices, they're analyzed using a framework called random utility theory.
Okay.
The basic goal is to figure out the systematic part of your choice, like how much did attribute A influence the decision, and separate that from the random sort of unexplainable noise component.
And what was the standard way of doing this for a long time?
Well, the traditional workhorse model, the one used most often, especially in the earlier period, was the multinomial logit model. You'll see it called MNL.
The workhorse. But I sense a but coming.
Yes, there's a but. The MNL model is relatively easy to estimate, but it relies on some pretty restrictive assumptions.
As.
Well, the most famous one is called the independence of irrelevant alternatives, or IIA.
Okay. What does that mean in plain English?
It basically assumes that the relative odds of you choosing, say, treatment A over treatment B shouldn't change if a third option, treatment C, is introduced or removed, which doesn't always hold true in real life.
I can see how that might not always work.
Another big one is that it assumes the random component, that noise, is identical for everyone and for all choices. And crucially, it assumes no taste heterogeneity.
Taste heterogeneity, meaning it assumes everyone has the same tastes, the same preferences.
Essentially, yes. It assumes that the relative importance people place on different attributes is the same across the entire sample. But we know that's often not the case, right? People value things differently.
Definitely. So if the MNL has these limitations, what's happened since? Have researchers moved towards models that are a bit more flexible?
Yes, exactly. That's been a major trend. There's been an exciting shift towards using more flexible econometric models that relax those MNL restrictions. The goal is to get more behaviorally realistic insights.
Like what kind of models?
Well, one example is the nested logit, or NNL, model. The review found it used in 5 studies in the later period, compared to none before. It allows for more general patterns of substitution between alternatives, grouping similar options together.
Okay. And any others that are particularly important?
Absolutely. The mixed logic model, or MXL, has seen a really significant increase in use. It went from just 1 study at baseline to 6 in the 2001-2008 review period. Sometimes it's called the random parameters logic.
And why is MXL so powerful?
Its main advantage is that it explicitly accounts for that preference heterogeneity we just talked about. It allows the coefficients, the weights people place on attributes, to vary across individuals in the sample.
Ah, so it doesn't assume everyone's the same.
Precisely. And this can lead to dramatically different conclusions. There's a great example in the review, a study on cardiac rehabilitation preferences. Let's call it Study A30.
Okay.
The initial analysis using the standard MNL model found that the attribute for group meetings wasn't statistically significant. It looked like people didn't really care about it either way.
Right. So maybe drop the group meetings.
Well, hold on. When they reanalyzed the same data using an MXL model, the group meetings attribute became highly significant
Wait, how can it be both insignificant and highly significant?
because the MXL model revealed why. It showed that there was significant heterogeneity. Some people had strong positive preferences for group meetings, they really liked them. But other people had strong negative preferences, they really disliked them.
Ah, so the MNL just averaged those out to 0.
Exactly. It masked this really important underlying variation. But knowing that some people love them and some hate them is crucial for policy, right? It tells you a one-size-fits-all approach probably won't work for that feature.
That's a fantastic illustration of why these more flexible models matter. It uncovers nuances the simpler models miss.
Definitely. And there's another one called the latent class model, or LCM. Only 1 study used it in the review period, but it's another way to handle heterogeneity. It tries to identify distinct segments or classes of people within the sample who share similar preferences.
So you might find, say, 3 different groups with different priorities.
Potentially, yes. Its advantage is sometimes easier in interpretation. You could describe the preferences of Class 1 versus Class 2.
Now, these more advanced models, MXL, LCM, they sound great. Are there any downsides or challenges to using them?
Well, they are more complex. They generally require more careful specification. You need to make certain assumptions about how preferences vary, for instance, and they often need larger data sets to estimate reliably. There's also always a risk of overfitting the data, meaning the model might capture noise specific to that sample rather than the true underlying preference structure. So you have to be careful.
But the big picture here, for you listening, is that researchers are getting better tools. These advanced techniques mean they can understand the diversity in your preferences much better, rather than lumping everyone together.
It allows for a much more tailored and nuanced picture of what people actually value in healthcare.
Which brings us to, arguably, the million-dollar question: validity, especially external validity. We've got these choices made in a hypothetical survey. How do we know if they actually predict what people would do in the real world?
Yeah, this is the gold standard, as you said, and it's a really tough nut to crack in health economics.
Why is it so hard in health?
Mainly because we often don't have a traditional market. People aren't typically choosing between competing hospitals based on advertised prices and attributes in the same way they choose, say, a brand of cereal. Access is often determined by insurance, location, referrals.
Right, the choices aren't always explicit or market-driven.
Exactly. So finding real-world behavior to compare the DCE predictions against is tricky. In fact, the review only identified 1 study during that period that directly tested external validity.
Only one.
Yes, a 2004 study by Mark and Swait. They compared doctors' stated preferences from a DCE about prescribing drugs with their actual prescribing records.
And what did they find? Did the DCE predict reality?
The results were actually quite encouraging. They found a reasonable degree of correspondence, suggesting that, at least for doctors making prescribing choices, hypothetical DCEs could reflect real-world decisions. But it's just 1 study in a specific context.
So if direct tests are so rare and difficult, what are the other ways researchers are thinking about external validity? What's the future direction?
Well, one approach is to use DCE models predictively. For example, use a DCE about patient preferences for a new screening test to predict its likely uptake rate, or maybe even the price it could command if it were marketed.
Okay, using it to forecast.
Another avenue is looking at methods used more often in other fields, like behavioral economics. Things like laboratory experiments, where choices might involve small, real stakes, or even natural field experiments that observe behavior in more realistic settings. These could offer complementary evidence.
So external validity is tough but crucial. What about internal validity, making sure the choices people make within the experiment are logical and consistent?
Right, this is about the integrity of the experiment itself. There are several types of internal validity tests. One common one is theoretical validity,
Which means,
basically checking if the results make intuitive sense. For example, do people generally prefer better health outcomes over worse ones? Is cost usually negative? Things like that. And the review found this is still commonly done, and the results are generally encouraging parameters mostly go in the expected direction.
that's good. What else?
Another test is non-satiation, which assumes more is always better for desirable attributes. But as we touched on, there's actually some debate about how useful this is in healthcare.
Because sometimes more treatment isn't better.
Exactly. More treatment might mean more side effects, more time commitment. So violating non-satiation isn't necessarily irrational in a health context.
Okay. What about basic rationality like transitivity? If you prefer A to B and B to C, you should prefer A to C.
Logically, yes. That's a fundamental axiom of rational choice theory. But surprisingly, testing for transitivity was really unpopular in the DCEs. Reviewed only 4% of studies did it.
Only 4%. Why so low?
It might reflect the practical difficulty of designing DCEs that allow for robust transitivity tests, or perhaps a growing sense among researchers that strict adherence to these economic rationality axioms might not always be the most important thing when understanding real human preferences in complex areas like health.
And that leads perfectly into something really fascinating. The review highlighted this whole debate around irrational respondents. Tell us about that.
This is really interesting. The review found that about 30 out of the 63 studies that were closely examined actually deleted respondents from their analysis if their choices were deemed irrational.
Deleted them. Based on what?
Based on violating certain economic axioms, like the non-satiation one we just discussed, or maybe always choosing the option with the lowest cost, regardless of other factors, things like that.
But is that the right thing to do? Just toss out their data?
Well, that's the debate. The review raises serious concerns about this practice. Firstly, deleting these responses might actually introduce bias. You're potentially removing a specific segment of the population whose preferences might be systematically different.
Right, you're skewing the sample.
And secondly, it reduces your sample size, which can lower statistical efficiency. But perhaps most importantly, subsequent qualitative research, actually talking to people about why they made certain choices, has found that seemingly irrational choices often have perfectly valid rational explanations behind them.
Can you give an example?
Yeah, someone might consistently choose a less effective treatment because they're terrified of a specific side effect associated with a more effective one, even if the risk is low.
No.
Or someone might violate non-satiation because they prioritize quality of life over just extending life by a few months with burdensome treatment. From a strict economic view, it might look irrational, but from a human perspective, it makes perfect sense.
That's such a crucial point. It highlights the limits of applying purely economic models to deeply human decisions.
Absolutely. And that's why we're seeing an increasing use of qualitative methods alongside DCEs. Things like focus groups before the DCE to help design it, or in-depth interviews or think aloud protocols during or after the DCE.
Think aloud, so people talk through their reasoning as they make the choice.
Exactly. These qualitative approaches help improve what's called face validity, ensuring the attributes and questions make sense and are interpreted as intended. But crucially, they also help researchers understand the why behind the choices, including those that might seem anomalous or irrational at first glance.
So really understanding the human context.
Precisely.
And all these validity tests, both internal and external, and the qualitative work, why does it matter so much for you, the listener?
Because it directly impacts how much confidence we, researchers, policymakers, and you can place in the results of these studies, especially when those results are being used to make big decisions about resource allocation, which treatments get funded, how services are structured, decisions that affect your access to care.
Without robust validity, the policies might not actually reflect what people truly need or want.
That's the bottom line.
Okay, so we've talked about how DCEs evolved, how they're designed, analyzed, and validated. Let's talk about where they're actually being used. You mentioned they started with patient experience.
Yes, valuing patient experiences was kind of the original focus, and it still accounts for a good chunk, about 35% of the studies in the review.
But they've broadened out quite a bit since then.
Oh, significantly.
Mm.
DCEs are now being applied across a really wide range of areas in health economics.
Like what?
Well, uh, valuing health outcomes themselves, understanding those tricky trade-offs people make between, say, better health outcomes versus negative side effects or inconvenient processes. They're used to estimate utility weights that feed into QALYs, the quality-adjusted life year calculations.
Which are really common in health technology assessment.
Exactly. They're also used to understand the job preferences of healthcare professionals. Why does a doctor or nurse choose one job over another? This helps with workforce planning. They're used to develop frameworks for setting healthcare priorities, deciding where limited resources should go, and even to understand clinical decision-making by doctors themselves.
That's a very broad scope. And what kind of outputs, what kind of results do these studies typically produce that policymakers find useful?
One very common output is willingness to pay, or WTP. This basically puts a monetary value on specific attributes or changes in attributes.
So how much are people willing to pay for, say, a shorter waiting time or reduced side effects?
Exactly. And this is obviously very useful for cost-benefit analysis in economic evaluations. Though there is some ongoing debate about whether deriving WTP directly from these choice models is fully consistent with the underlying random utility theory, but it remains popular.
Interesting. What else? You mentioned utility scores earlier.
Yes, the models inherently estimate these underlying utility scores for different attribute levels. But interestingly, using these scores directly as the main output hasn't really gained that much traction,
Why not?
partly because there are questions about their interpretation. Are they truly cardinal measures, meaning the difference between a score of 2 and 4 is the same as the difference between 6 and 8? It's not always clear. Also, comparing utility scores across different studies can be difficult.
So WTP is common, direct utility scores less so. What about other outputs?
We're seeing increasing use of things like odds ratios or predicted probabilities. These are really useful for policymakers because they can help assess the likely take-up or acceptability of a new drug or intervention.
Can you give an example?
Sure, a study might use a DCE to predict what proportion of the target population is likely to choose a new chemotherapy drug with a specific side effect profile. That was study C5 in the review. Or estimate how likely parents are to accept a new childhood immunization program with certain characteristics, like study C4.
So it gives a direct prediction of potential real-world behavior or adoption rates.
Yes, which is incredibly valuable for planning and policy.
Now, despite all these advancements and the broadening applications, are there still persistent challenges or areas where DCEs need improvement?
Oh, definitely. The field is still evolving. One really crucial area that needs more research is how to better explain attributes related to risk to respondents.
Risk of side effects, risk of treatment failure.
Exactly. People often find probabilistic information difficult to understand and process consistently in surveys. And the review noted that surprisingly few studies, only 2 back then, used visual aids or other tools to try and help communicate risk more clearly.
That seems like a gap.
It does. Another ongoing challenge is managing the cognitive burden on respondents. We talked about the trend of fewer attributes, but more choice sets. While that might help with each individual choice, making 14 or 16 choices can still be demanding and tiring for people.
Sounds like trying to pick a new phone plan sometimes.
Exactly. It really highlights the critical need for careful pre-testing and pilot work to make sure the task is manageable and people can provide meaningful answers throughout.
And what about the disconnect with major evaluation bodies like NICE in the UK? Are DCE results being fully integrated there?
That's another significant challenge. Despite the growing sophistication and use of DCEs in research, they still seem to be largely absent from the main frameworks used by major health technology assessment bodies like NICE.
They still prefer QALYs based on other methods.
Primarily, yes. They often rely on methods like time trade-off or standard gamble to get the utility values for QALYs. So there's still a gap in translating the rich preference information from DCEs into those high-level decision-making processes. Bridging that gap is important future work.
So wrapping up that section, it sounds like DCEs offer this incredibly rich toolkit for understanding preferences way beyond just clinical effectiveness. They bring in patient experience, trade-offs, even likely adoption rates.
Exactly. It's about building a much more complete, holistic picture of value in healthcare, reflecting what actually matters to people.
Well, we have certainly covered a lot of ground today, unpacking the world of discrete choice experiments. We've seen their uh, really rapid growth, the evolution towards more sophisticated designs, more flexible analytical models.
And that ongoing, really crucial quest for robust validity, making sure the results are trustworthy and reflect reality.
It's clearly a powerful and increasingly vital tool in the health economics toolkit.
Absolutely. And these experiments, at the end of the day, they're allowing researchers to get a much better handle on what you, the patient, the citizen, actually value when you're faced with these complex, often difficult healthcare decisions. They're trying to capture that diversity of human needs and priorities.
So as we finish up, here's something to maybe mull over. Given that DCEs are trying so hard to capture the real nuances of human preferences, including choices that might look irrational from a purely economic standpoint, how much weight should policymakers actually give to that strict economics definition of rationality?
Versus the real world, sometimes messy but deeply understandable human reasons people have for their healthcare choices.
Exactly. Where should that balance lie?
It's a fundamental question, isn't it? And maybe one for you listening to consider too. When you think about your own healthcare preferences, what attributes, what features really matter most to you? And how would you want your voice, your values to be heard in these critical policy discussions that shape the future of healthcare?